right, our next rapid-fire presentation is postoperative and long-term outcomes of de novo versus post-repair ruptured abdominal aortic aneurysms in VQI-medicare-linked database, presented by Austin Fan from the group in San Diego with the senior author of Dr. Malas.
Hi everyone, my name is Austin. I'm a second-year medical student at UC San Diego, and I'm presenting on my research with Dr. Malas. We do not have any financial disclosures related to this study. A ruptured abdominal aortic aneurysm, also known as a ruptured AAA, is a detrimental event with a mortality rate of nearly 80%. Ruptured AAAs can happen in patients with no history of aortic intervention, known as a de novo rupture, or in patients who have undergone previous aortic repair, such as an endovascular or open. Regarding post-repair ruptures, a previous study has indicated that 30-day mortality of post-EVAR rupture is 32%. Additionally, a separate study has indicated that there are no differences in perioperative mortality between a post-EVAR rupture and a de novo ruptured AAA. This is interesting because there are conflicting reports on mortality, and previous studies have been limited to short-term outcomes, with main studies focusing on EVAR and few studies, if any, on postoperative or long-term outcomes of post-OAR rupture. In our study, we compared the postoperative and long-term outcomes of de novo versus post-repair ruptured AAAs. In the VQI-medicare-linked vision database, we evaluated 2,700 ruptured AAAs, with 93% being de novo ruptures and 7% being post-repair ruptures. Each rupture was treated with either an EVAR or open. Our primary outcomes were 90-day, 1-year, and 5-year mortality, while secondary outcomes were postoperative complications, 5-year re-rupture, and 5-year re-intervention. Short-term outcomes were evaluated using logistic regression, while long-term outcomes utilized Kaplan-Meier survival and Cox regression. Starting with our patient demographics, I would like to point out that the post-repair group was more likely to be older, have comorbidities, and utilize preoperative medications. Moving on to our results, interestingly, there were no significant differences in postoperative outcomes between de novo ruptured AAAs and post-repair ruptured AAAs, as indicated here. With our long-term outcomes, interestingly, there were no significant differences between 5-year mortality, 5-year re-rupture, or 5-year re-intervention when comparing de novo ruptured AAAs and post-repair ruptured AAAs, as indicated here. We wanted to perform a separate sub-analysis stratifying the population by repair type, still comparing de novo ruptures and post-repair ruptures, but looking at patients just treated with EVAR, and a separate analysis looking at patients just treated with open. Similar to our primary analyses, there were no significant differences in outcomes, with one notable outcome. Post-repair ruptures treated with open were associated with an increased risk of 5-year re-rupture when compared with de novo ruptured AAAs when treated with open. Our study was limited by its retrospective nature, which can limit a lot of the variables available for analysis, one of the most important being the reasoning why a surgeon chose to pursue EVAR or open for that specific patient. With any large database study, there's a potential for underreporting, coding errors, and missing data. In conclusion, our study suggests that post-repair ruptures are not associated with significantly greater risk for mortality or re-intervention when compared to de novo ruptures. And although ruptured AAAs, whether de novo or post-repair, they should be treated with a procedure best suited for the patient. And they should be considering their patient anatomy and various factors. But our study does suggest the rate of re-rupture is increased for post-repair ruptures, ruptured AAAs receiving open, compared to de novo ruptured AAAs receiving open. And I just want to finish off with my acknowledgments. Thank you.
Hey, nice talk. Interesting subject. I think I agree with you. It hasn't been studied very much. Just to clarify, the initial procedure for these late ruptures, it was always EVAR?
Yeah, that's a great question. So the previous procedure and the post-repair group could have been either EVAR or open.
So how do you re-rupture after an open repair? I think what you're probably seeing are ruptures at different sites in the aorta, so paravisceral or like perianastomotic pseudoaneurysms, for example, because if it's done properly, and I think we can hopefully assume people do it, you can't really rupture after an open repair in that same segment.
Yeah, when doing the analyses, we were sort of organizing the patients that were presenting with a rupture, and for those specific patients, they were recorded as having a previous open repair on their aorta.
I think it's just the downside of a database like this that doesn't have anatomic information, just probably important to put in your limitations section in your manuscript.
Yeah, definitely, that's a good point.
Just a quick question. You know, when you have a really large cohort and a really small one, so you're 10 times more, and all of the things are different, you need to do a propensity match or something to kind of bring them together, because you're not really comparing apples to apples here, I think. And we don't know much about, you know, what the pre-operation was, but what you do know, those two cohorts are very different. So I think you should consider doing that for the manuscript.
Yeah, moving forward, we'll definitely try to do that analysis.
Great, thank you.
Cool, thanks.